I'm going to focus on diabetic neuropathy, as the other speakers have. But then when I was talking to Ariel, he said, suggest a title. And, honestly, this just came up out of the blue. I thought, why don't I think about diabetic neuropathy as being the good, the bad, and the ugly? So where did I get this title from? Well, I have to acknowledge that actually is from one of my all-time favorite films, from the famous spaghetti westerns that Clint Eastwood used to make. And so in that, there is a film that I would recommend all of you watch called The Good, the Bad, and the Ugly. And it serves as a framework, I think, for me to establish in terms of diabetic neuropathy, what we have that is good, what we have that is bad at the moment, and perhaps what is the ugly. So I think everybody would agree that an ugly fact of diabetic neuropathy is the following, which is the inevitable outcome in people who have diabetic neuropathy, who aren't diagnosed, who develop foot ulcers, and then undergo an amputation. And the focus of my talk really is, how do we prevent this? How do we do something that is effective? And actually, I put up this quote from Machiavelli, from The Prince, which I think is the core of what I'm going to talk about. And Machiavelli said, as the doctors say of a wasting disease, to start with, it is easy to cure, but difficult to diagnose. After a time, unless it is being diagnosed and treated at the outset, it becomes easy to diagnose, but difficult to cure. Of course, Machiavelli was talking about politics, but I want to refer you to diabetic neuropathy and what I think we're doing wrong, in that when we are approaching a patient and doing simple clinical bedside tests, even the monofilament clinical neurological exam, it is diagnosing disease that is advanced. And therefore, we are not picking up the disease at an early enough stage where we can do something about it. And I think that is where there is a real problem. And we need better, easier tests to achieve this. And that's where I think, diabetic neuropathy is bad. It remains the Cinderella complication. Why? Because if you look at the other two complications, diabetic retinopathy and nephropathy, we've got advanced systems which are able to detect disease at the very earliest stage, and we're able to do something. Whereas in diabetic neuropathy, we rely on this, time and time again, you hear the experts talking about how we should diagnose diabetic neuropathy. And we are happy to say, oh, it's okay to just examine the foot or do a monofilament exam. Yes, it is okay to do a monofilament exam if you want to identify people who've got advanced diabetic neuropathy, i.e. those at risk of foot ulceration. It is not good enough to use these tests to diagnose early neuropathy. Simple. And actually, this also then reflects on how we as physicians, which is, I guess, diabetologists, think about diabetic neuropathy in the clinic setting. And we did this survey actually in Southeast Asia, where we went to several different countries and looked at what physicians, when they see a diabetic patient, what they think about. So here's what they think. First and foremost, as soon as the patient walks through into the clinic, they think about controlling the HbA1c, maintaining kidney function, managing their lipid disorder, managing their blood pressure. Do they think about painful neuropathy or neuropathy, which can be easily actually painful neuropathy? You can assess just by asking a few questions. Actually, very little. You can see, depending on Hong Kong, Malaysia, Philippines, Taiwan, Thailand, very little attention to diabetic neuropathy. And that was emphasized when I actually moved to Qatar. Being interested in diabetic neuropathy, I thought, we'll see what interest is out there. And we did a study. The first study was a prevalence study in secondary care of 1,171 patients. And we established that 34% of people in secondary care had diabetic neuropathy. And it varied in terms of its prevalence. Actually, in fact, the local Qatari Arabs had the highest prevalence of 44%, and the Caucasians had the lowest, around 22%, which you'd expect. And then we also found that there were risk factors, particularly obesity, which seems to be a major risk factor in the Middle East. But the most important thing that we learned from this was that, in fact, 80% of these people we diagnosed with diabetic neuropathy, based on actually on a DM4 and vibration perception, had not previously been diagnosed. Why? Because they'd never been examined, or nobody had asked, the clinician never asked the question whether or not they've got symptoms. And we've now followed that up with actually a much larger study, again, BAD, in 3,000 patients across secondary care, again, in different Gulf countries, so Kuwait, Qatar, Saudi Arabia. What we show, again, is similar results, actually, that diabetic peripheral neuropathy is present in around 20 to 40% of people in different countries. So that's the Gulf Arab states altogether. You can see around 30%. However, of those people who've got neuropathy, actually 50% are at high risk of diabetic foot ulceration. And about 2% already have a diabetic foot ulcer, and around 40% have painful diabetic neuropathy, which is almost double that in the European and US populations. But again, what is the key message that comes out is that over half, 54%, have not been diagnosed or treated. And again, actually, they have risk factors. So being older is a risk factor, having a longer duration of diabetes is a risk factor, having poorer glycemic control, hyperlipidemia, being more obese, are all risk factors that I believe, if we can detect this condition earlier, we can actually do something about this. So we can improve their glycemic control, improve their hyperlipidemia, improve their obesity, ask them to exercise more, stop smoking. So that, you can do to prevent the progression of this disease. And I think one of the core things that really the other speakers have touched on is, of course, the type of fibers that we assess when we assess for diabetic neuropathy. And therein, I think, is a major problem, in that we are so heavily focused on neurological examination, monofilament, and perhaps even vibration perception. And what are we looking at? Well, we're looking at the A beta fibers. And as Ariel mentioned in his introduction, we're actually ignoring the small fibers. The small fibers are actually where I believe two things. One, if you've got painful neuropathy, that's where you should be looking, not using a monofilament. And if you've got diabetic foot ulcer, and I'll show you, actually small fibers are really quite important in terms of the relation to blood flow, in relation to inflammation, and they play a key role in the development and progression of a foot ulcer. So I think it's time for us to actually say, well, we need to open our minds and have the courage to throw out yesterday's ideas when they don't appear to be working. So yes, the neurological exam, monofilament vibration perception works, but is it really doing what we want to do in terms of detecting early diabetic neuropathy? And the answer to that is no. So we need to look at something else. And perhaps that is looking at the fibers that are related to or associated with painful neuropathy, but also regulating blood flow, inflammation in the skin that is related to actually the development of reduced blood flow and tissue breakdown with foot ulceration. So how can we do that? Well, of course, we have to turn to my favorite technique, which is, and I also then put out a quote for you, which Albert Einstein put out, which is, how we think determines what we measure. So how we think up here is going to make a difference in terms of what we do for our patients with neuropathy, diabetic neuropathy. And I think about 20 years ago, had this moment of madness maybe, where we thought that we could look for diabetic neuropathy by looking in the eyes, using this technique called corneal confocal microscopy. This is a rapid, non-invasive way of detecting early small fiber damage. And it starts with a very little, I would say, simple study. 18 patients, healthy controls as well in that, but 18 patients with mild, moderate, and severe neuropathy. And the key finding in 2003 was that actually, if we used the monofilament, then we would have detected neuropathy at this advanced stage in the severe neuropathy group, but we would have missed the moderate neuropathy and the mild neuropathy. But CCM was able to detect early phases of disease and early loss of nerve fibers. So that was with the 18 patients in 2003. But now we have actually done a meta-analysis recently of 38 studies using corneal confocal microscopy, over 4,000 patients, and we show exactly the same. That is, that if you compare healthy controls with people with established diabetic neuropathy, that is severe or moderate neuropathy, then there is a significant loss of corneal nerves. But also, more importantly, even if we look at this group, which is mild to minimal neuropathy, which would be considered as no diabetic neuropathy, we also find a loss of corneal nerve fibers. This to me tells me that this is a test that can pick up very early subclinical neuropathy and more advanced neuropathy. And to make life easier, we actually now have a paper published recently that has incorporated artificial intelligence into this process. So it allows us to pick these images up, rapidly quantify them in a few seconds, and then apply logic-based fuzzy inference models and deep learning to actually come up with this, which is a 100% sensitivity and a 95% specificity for detecting diabetic neuropathy. And then differentiating those with and without diabetic neuropathy, again, very high sensitivity and specificity. And this can all be done like that. And if we go back to what matters in the clinic, again, if you have painful neuropathy, it is really pointless doing a monofilament because that is not the nerve fibers that underlie painful diabetic neuropathy. And if we look at CCM, then what you see here are a number of reports now coming through that actually show you that looking at small fiber damage using CCM can help you to identify people with painful diabetic neuropathy. And so you can see here this cohort, if you look at whether it's corneal nerve fiber density, branch density, length, or inferior wall length, in the people with painful diabetic neuropathy, you can see they have more damage compared to those with pain less and compared to healthy controls. Furthermore, we have now gone on to show that not only is it a corneal nerve damage present in those with painful diabetic neuropathy, but it relates to the severity of pain. So, first of all, again, diagnostically, ROC curves show that we can pick up people with painful diabetic neuropathy compared to painless diabetic neuropathy using CCM. And it relates to severity. So the more severe the pain, the greater the loss of nerve fibers. You can see here controls, no pain, mild pain, and then moderate to severe pain. And also, more importantly, and this is where I think CCM would really come into its help you in the clinic. Thomas Campbell said, coming events cast their shadows before. So can we use corneal confocal microscopy in the clinic in a patient who has not yet got neuropathy and be able to predict those that will develop neuropathy? Well, as part of a big consortium, and Radhika was a part of that, Nathan Ephron, Bruce Perkins, we actually did a large longitudinal study of over 998 patients with type 1 diabetes, type 2 diabetes. 261 of these patients at baseline had no diabetic neuropathy that we could measure from quantitative sensory testing, neurophysiology, symptoms, and signs. And so what we did is we followed those patients up over 5.8 years, and about 23% developed diabetic neuropathy according to DNSS, the NDS, symptoms and signs, abnormal nerve conduction. We then went back and looked at what was abnormal in these patients already or was different compared to those who didn't develop diabetic neuropathy. Well, comparing those who did not develop diabetic neuropathy, that's 201 compared to 60 who developed diabetic neuropathy. Interestingly, we found actually that those who developed diabetic neuropathy were more overweight. But really no difference in HbA1c or lipid profile. And if you look at their signs and symptoms, sural nerve amplitude, nerve conduction, perineal nerve amplitude, perineal nerve conduction, it was more abnormal in those who developed diabetic neuropathy. Although subclinical at that stage, it was nevertheless more abnormal in those who developed diabetic neuropathy. And corneal confocal microscopy, you can see that significantly all three parameters were lower in those who developed diabetic neuropathy 5 years later compared to those who didn't. And if you looked at that in terms of this log rank score, you can see that if you had a patient who had a corneal nerve fiber length which was less than 14.1, then they had a highly significant chance of developing diabetic neuropathy. And I'll kind of finish off with the other thing where I think is really important of, Niels talked about prevalence, Radhika talked about prevalence, but where it's really important that we measure neuropathy in an accurate way is in the setting of a clinical trial. Why? Because we know we have no current treatment for diabetic neuropathy, pathogenetic therapy. And again, the previous speakers talked about the multiple mechanisms. And we know that in the lab, there are all these multiple mechanisms that lead to neuropathy. But when it comes to patients, we have no active therapy that can actually repair nerves. And I think that's where the endpoints that we've been using are a problem. And that's bad. So can we have a good outcome? Well, I'm just going to share one clinical trial with you. And this is in the setting of people with type 2 diabetes who were either given poor control, HbA1c of around 10.5%, either given basal bolus insulin or a long-acting once weekly exenatide with pioglitazone. And what we show is that you can, in these patients, you can clearly get the HbA1c down into almost normal level from 10% to 7%. We then measured neuropathy using CCM, vibration perception, and pseudoscan. And what did we find? Well, over 12 months, actually we showed nerve fiber repair in the corneal nerves. So what you see here is in both arms, you got a reduction in HbA1c, there's an increase in corneal nerve fiber density, branch density, and fiber length. But look at vibration perception, which is actually a commonly used test in a lot of the old clinical trials. In one group, despite having a lowering of HbA1c, you get this improvement. But yet, in the basal bolus insulin group, we actually had a reduction in VPT, an increase in VPT. So it really, the signal is all over the place, and pseudoscan didn't improve. And last but not least, the other bad thing that is maybe going to be affecting us going forward in our diabetic patients is COVID and its potential effect on making nerve damage that's already present in our diabetic patients even worse. And really, I have to thank Ariel for this, because he kind of came to me and said, look, you've got these 4 cases of patients who came and they had severe COVID. So 4 patients had severe symptoms, dyspnea, fever, consolidation on the chest x-ray, obviously SARS-CoV-2 positive, were intubated. And then what they did is they looked at symptoms, and they found that the symptoms had worsened, i.e. painful symptoms. They'd lost their tendon reflexes, lost taste, lost smell. But then Ariel, as he does, used the nerve checkmaster. And what they showed is very beautifully that actually these patients now had developed really quite really abnormally high heat pain thresholds, and some abnormality actually in some patients in vibration perception, cold perception, warm perception. Again, suggesting to me that this is a small fiber hit that is from the COVID infection. There is a remnant of the COVID infection. So to finish off, we've actually done a study now where we looked at patients, non-diabetic, with no previous neuropathy, young patients, about 4 months after they developed a COVID, they recovered from COVID actually. And we used the long COVID questionnaire, which essentially allows you to quantify whether or not there is ongoing symptoms like loss of taste, loss of smell, and neuropathic type symptoms. And we also did the DM4 questionnaire, which just about reached significance, suggesting that these patients have ongoing neuropathic symptoms, but also the fibromyalgia questionnaire, which tells you that they definitely had musculoskeletal type of symptoms. And then, of course, we did corneal confocal microscopy. And to our surprise, we found that people who had long COVID, according to this questionnaire, had less corneal nerves, but they also had more immune cells in their cornea. So these Langerhans cells, which are dendritic cells, were increased. This is after they'd recovered from their COVID. And for those of you who are interested in beyond citation, although this has been cited now 20 times already, the altimetric score, which is the current kind of favorite for most people to see how important something is. We have got an altimetric score at the moment in British Journal of Ophthalmology of 1,532. Most papers get an altimetric score of around 20. The research that we've published is in the top 5% of all research outputs scored by altimetric, and it's one of the highest scoring outputs from the source. So the eye is the window to the soul, not S-O-U-L soul, but S-O-L-E, soul, the foot, and beyond. And I hope I've left you a message that there is something good, and we've got rid of the bad and the ugly. Thank you.